Assalamu alaikum warahmatullahi wabarakatuh. We talk here about the cardiovascular examination in pediatric patients, which will include history taking and cardiovascular examination. Always you should remember certain symptoms as presented symptoms of the cardiovascular disease, and the most common is the symptoms of the heart failure, which is depends on the age group of the patient. If in the infant, usually the main exercise is the feeding, so we should ask about if there is any interrupted feeding, there is intolerance of the feeding, sweating during the feeding, poor feeding, that all mean that there is heart failure in that infant, while the older children usually they were presented with the symptoms of adults like easy fatigability and exercise intolerance. Next most common is the cyanosis, and the cyanosis we should ask about the onset of the cyanosis and whether it is persistent or intermittent and whether it's central or peripheral. The next common is the chest pain, and chest pain usually expressed only in the older children, and we should ask about all the criteria, we should ask about the pain in any other, so that we can differentiate whether the origin of that chest pain, whether cardiac, respiratory, or musculoskeletal. Next common symptoms of the cardiovascular disease is the palpitation, and we always stress on the point that the history in the pediatric group should be oriented and related to the age group, so that the palpitation only can be expressed by the older children because they are only can aware about their cardiac beats. And the next symptoms is the syncopal attack. You should ask if there is any syncopal attacks, and the last symptoms is the edema, which usually in the infant, usually in the demented part, while in the older children usually can be visited as peripheral edema in the fetal leg. There's some general principles I like always to remind you about the history that the present illness is started from the onset of the symptoms till the time of the hospitalization. And the present illness should be divided into three imaginary parts. The symptoms from the onset of the symptoms till the time of the admission, and then you should include the general symptoms which we included in, and this should you focus on one of the systems. Then the second part is the general symptoms, which include the fever and the well-being, the weight loss, and and if there is any weight gain or loss. Then the next point, the third part, imaginary part of the present illness, is the history of hospitalization and should be included in the present illness and should involve all the symptoms. And suppose that the patient presented admitted because of the cough or shortness of breath, and during his hospitalization developed diarrhea, that should be included, or headache should be included in the present illness. So, and just to remind ourselves, the patient is diagnosed and proved to be have a certain diagnosis. We should start it with the sentence that it is a known case, such as a known case of congenital heart disease, a known case of diabetes, a known case of asthma, whatever, because that's make much difference in our interpretation of his symptoms. The other part of the history which should be focused on is the prenatal history, and if the mother has a regular prenatal care, and we should ask if there is any history of diabetes and the type of the treatment the patient receives, and if there is any hypertension. These two chronic conditions is important because the diabetes, whether it is gestational or the non-case of diabetes, can cause a congenital anomalies such as TGA and other common truncal anomalies, and hypertension can cause small or late unit, and the other we should ask the mother if there's any history of long-term of medication, whatever this medication it can cause teratogene in the baby, such as sodium valproate can cause a congenital heart disease. And our questions should be included if there's any fever and if there's any skin rash, because this indicates some of the infection which can cause a congenital anomaly such as rubella, which can be presented with fever and rash. Prenatal history is also important because it would indicate the health being of the neonate at birth. So we should ask about the birth order for the vaginal or cesarean section, and if the baby is a full term or prematurity. As we know, the presentation of the congenital heart in the prematurity will be presented earlier, and the incidence of the congenital heart disease will be more in the premature baby rather than the full-term baby. And also our list of questions should include whether there is any cyanosis which is developed early during the neonatal period, and that indicates patient the presentation is severe, and if there's any admission to the neonatal care unit, and those will indicate the good parameters about the type of the congenital heart disease and the severity of that congenital heart disease. Next part of the history should include any past medical or surgical history. So we should ask about any history of hospitalization, and we should know the duration of that hospitalization and the indication of each hospitalization really in a brief. And this may indicate that in patients with the left right shunt and heart failure presented with recurrent respiratory tract infection, while those with the cyanosis may be presented with a recurrent hypercyanotic spell, which is all of these may be the causes of their recurrent attack of hospitalization. And we should include the type of the medication the patient chronically used, and just we refer that the patient had medication to heart failure or enteral or whatever, and we should not go in detail. And also our history should include any history of surgery, and whether it is a good center here or abroad, and try to know the type of the surgery, although not in details, although it's allowed for the history taking person to take the previous papers of the history and know the details of the history, whether it is radical or palliative history regarding to the congenital heart disease. The other important part of the history is the family and social history. Family history of any congenital heart disease is important because, as we know, the congenital heart disease is multifactorial in inheritance. So it is important to know if there's any sibling with the congenital heart disease, or the parent themselves has a history of congenital heart disease, and will make the incidence is more. And we should ask if there is any neonatal or infantile death, because that may due to undiagnosed congenital heart disease. And we should ask if there is any sudden death, because certain congenital heart disease are acquired sometime, inherited, such as hypertrophic cardiomyopathy, which is inherited as autosomal dominant, and the only presentation is the sudden death. And all these points make the awareness about the congenital heart disease is more. Cardiovascular examination in pediatric patients include, first of all, general examination, and then we should check the vital signs and the measurements, including weight and height and chest circumference, and the last is the precordial examination. The general examination in pediatric patient different from the adult. In pediatric we have no regional examination supposed to be head and neck, mouth and eye. All these notes should be included within the general examination. So the first of all we should check the general looking of the patient whether he is dyspneic, and we should note all the signs of the dyspnea including flaring of alenesis, subcostal, intercostal recession or suprasternal recession, and if the patient obviously tachypneic and the type of respiration, all should be mentioned in the general examination of the cardiovascular symptoms. Then we should check whether the patient cyanosis, central or pleural cyanosis, and the deepness of the cyanosis. With the cyanosis, we should look if there's any clubbing and the degree of the clubbing, whether include toes and nails or just the nails, and the degree sometimes severe or mild clubbing. And then we should mention whether there's any pallor, and you know that there's a list of causes of the pallor started with the anemia, and the patient or with the heart failure usually look pale because of the sympathetic overdrive, so that you can check whether the patient is or hypovolemic, and in patient with the heart failure whether it's hypovolemia. All these included in the general examination. The other point you should check in your patient if there's any dysmorphic features, and if there's that refer to any specific syndrome, and we know that the most common syndrome was associated with the congenital heart disease is the trisomies, and the most common syndrome of the trisomy is the Down syndrome, where 50% of the patients with the Down syndrome had a congenital heart disease, and 50% of this congenital heart will be the IV canal. So we should check the sign of the Down syndrome, including the slanting of the eyes, the small mouth, protruding of the tongue, and if there's any sign of other trisomies such as Turner syndrome, we will find hypertonia and hyperreflexia, and if there's any sign of the Turner syndrome, where 30% of those with the Turner syndrome had congenital heart disease, and the most common congenital heart disease is the coarctation of aorta. Beside the Turner syndrome, if it is male and has sign of the Turner syndrome, will be suggest features of the Noonan syndrome. And the last to be mentioned, the first to be checked in the vital sign is the pulse, and usually we use in the older children is the radial pulse, but in the neonate and the small infant may be difficult to check the pulse from the radial arteries. You can use the brachial, and if it is also difficult, you can use carotid, and if it is also difficult, you can use your stethoscope and calculate and check the information from the heart. First of all, to be checked in the pulse is the rate, and everyone should be familiar with the maximum normal for each age group. Supposed to be that in neonate the maximum normal is 180, while in the infancy it's about 160, and then in the older children it's like the adult 98 to 100. So we should be familiar with the maximum normal rate for each age group. And during our checking of the pulse, we check whether it is regular or irregular, and the other point should be checked is the volume of the pulse, and it could be normal or could be a small volume, and that either the patient have a heart failure or hypovolemia, whatever the cause of the hypovolemia. And there's some characteristic type of the pulse. We called it collapsing pulse or water hammer pulse, which is that frisky, and it is caused by the pathophysiology of this collapsing pulse is the wide pulse pressure. The difference between the systolic and the diastole. And there's a list for the causes of this collapsing pulse. Anyone can ask about you. Started from the fever or anemia or pregnancy or pathological cause such as patent ductus arteriosus or aortic incompetence or any peripheral fistula. This all can cause a collapsing, what we call the collapsing pulse. And the last point should be checked in your examination of the pulse is to compare between the radial and the femoral pulse. And because this is a hallmark or clinical hallmark or to diagnose the coarctation of aorta, which is from about 10% of the congenital heart disease. Then you should check the respiratory rate, and again you should be familiar with the maximum normal of respiratory rate for each age group, and then the temperature. The temperature, you know that in the neonate, the preferable way is to measure the rectal, and that means you should subtract half half centigrade degree, while in the infancy and up to the toddler age, you can use the auxiliary, and that you should add half centigrade degree, and in the older children you cast the oral, you put the temperature, you put the thermometer in the mouth of the patient, and it should be left at least 1 minute. The other vital sign should be checked is the blood pressure, and this is the most frequent for getting vital signs to be checked in the pediatric age group, and that's because of there should be special cuff for each age group, which should cover only 2/3 of the arm, and there's a special way to calculate for the normal blood pressure for the each age, but there's a general simple principle that in the neonate the systolic is 90, while the infancy the systolic is 100, and then you can add 2 degrees for each year, and this is roughly to know, but you should go to put it in the special algorithm. The last point, if you can check, is the SpO2 by the oximetry, and now they consider it as part of the vital sign which should be available bedside, and this gives you much information whether the patient is cyanotic, if the O2 saturation less than 90, or it is acyanotic, and this is important. And even in the acyanotic patient, you should check the degree of the disease, such as associated with the chest infection or whatever. Then we do the precordial examination, and the precordial examination we follow the same system in any examination, that we start with the inspection and then palpation, followed by percussion, and the last is the auscultation. So we should look to the precordium and the chest and see if there's any obvious abnormality. The most common is the bulging of the left side of the indentation to the lipocardia, which indicate active precordium. And then you will see if there's any previous scar, such as sternotomy, which is indicate there's a previous cardiac surgery, such as open heart surgery or sometimes late heart surgery, or if there's any lateral thoracotomy, incision, which indicate if there's any surgical PDA closure, or sometimes the coarctation repair then through that lateral thoracotomy. And then the next step is see if there's any obvious pulsation, but the most important part is to determine the apex speed. And the definition of the apex speed is the lowermost, outermost, visible and or palpable cardiac pulsation. So we should look to the intentional view to the precordium and if we can determine the location of the apex. Then we proceed for palpation, and for palpation we complete determine the apex beat. We can't determine by just inspection and determine its size and whether it is in the mid clavicle line or shifted to the left, and that indicates the cardiomegaly. The other part by palpation is the thrill, and the thrill we mean by it is the palpable murmur, and we should determine its size in which intercostal space, and so we can determine it related to which valve. The other part which should be done by palpation is the parasternal or subxiphoid heat, which indicate right ventricular hypertrophy. And the last point should be checked is if there is any hepatomegaly, because in patients with the heart failure usually have a tender hepatomegaly. Really, the auscultation is the most important part of the examination, and that's mean the part that we can get much information about the heart status. So we'll start to discuss where you can listen to get the best area to hear and to listen to the heart, and what's the type of the heart sound, and if there's any other sound, and lastly we'll talk about the murmur. What we mean by the areas of auscultation, usually there's four areas where we can listen to the heart. The first is the mitral area, or what we call the apical area, and usually it's in the fourth or fifth intercostal space at the mid-apical line. And if we hear murmur, usually it's the murmur originated from the mitral valve. And the second area where we can listen to the heart sound and any normal or abnormal heart sound is the tricuspid valve area, where and it is in the lower left sternal border, usually at the fourth intercostal space. And the murmur, if you hear murmur here, usually it's the murmur of tricuspid valve or murmur of the ventricular septal defect. While the pulmonary area, it is the area in the left upper sternal border, usually in the second intercostal space, and the murmur here, you can hear the murmur of the pulmonary valve or the murmur of the atrial septal defect. While the aortic valve area is located in the right upper sternal border, usually in the second right upper sternal border, and usually any murmur here means that it is originated from the aortic valve. First part of the auscultation to listen is the heart sound. And usually there is S1, S2, S3, and S4. First heart sound usually it is produced by the closure of the mitral and tricuspid valve during the ventricular systole, and in the pediatric age group usually it's almost always normal because in the adult it's only allowed to and there's a mitral stenosis, which is a rare disease in the pediatric age group. The second heart sound usually can be heard in the upper left sternal border, and it is usually the most important part of the auscultation, because we can get much information if there's any abnormality, because if it is fixed, separated, usually it is normally separated, the aortic closed before the pulmonary valve, so it is normally separated during the inspiration. If it is fixed separating, usually that indicates the patient had ASD. If it is non-fixed separating, that means there is a pulmonary stenosis. And if it is single, that means there is subpulmonary stenosis. So if it is loud, that indicates there is a pulmonary hypertension. So the second third sound is important to be listened very well. The third sound, it is usually a low pitch sound. That means you can hear only by the bell, and usually it's placed here at the apical area, and it could be normal, but sometimes if it is pathological and if it's associated with the gallop rhythm, usually we call it switch with the tachycardia, usually called it the gallop rhythm. Fourth sound is almost always is normal, and also it is a low pitch sound that also can be heard after the second sound and usually heard at the apical area. The last point we should discuss in the section of the heart sound is the added sound. What do you mean by the added sound? The added, any abnormal sound which is classified not as a murmur, such as the clicks, which is the hallmark of the valvular stenosis. So we can hear the click in the pulmonary valvular stenosis, the aortic valvular stenosis, and the patient with the PDA, usually we hear a continuous machinery murmur. And why we call it machinery? Because it is both systolic and diastolic murmur, but in addition, there's multiple clicks which make this a murmur. Last part of the auscultation of the heart sound is which we called it in the added sound. What we mean by the added sound is the any other sound rather than the heart sound and the murmur, which such as the clicks, which is the hallmark of the valvular stenosis. So in the pulmonary valvular stenosis we hear clicks or aortic valvular stenosis, and other added sounds such as pericardial fraction rub or any other sound cannot be classified as murmur. For each murmur, there is 5 criteria should be checked and should be listened and should be known about. First of all, the maximum site of the murmur, because it's according to the site we can put a differential diagnosis. So if the maximum area to be heard to hear that murmur, if it is in the apical area, that means there is some pathology in the mitral valve. While it is the lower parasternal area, means there is related to the tricuspid valve or ventricular septal defect. And if it's here in the left upper sternal border, that means it is related to the pulmonary valve. While the murmur here in the right upper sternal border, that means it is related to the aortic pathology. So if we hear a systolic murmur in the mitral area, the panstolic murmur, that means it is mitral incompetent. While if it's here a diastolic murmur, then it means a mitral stenosis. While the same principle applies to the tricuspid valve, and you know that the most common murmur is the pansystolic murmur in the pediatric age group, which is related to the ventricular septal defect. While in the pulmonary stenosis, usually in the pediatric age group, usually here the most common is the systolic murmur and usually related to the pulmonary stenosis, and the same principle in the aortic area, right upper sternal border, that means it is aortic stenosis. The next criteria should be checked in the murmur is the timing of the murmur. What we mean by the timing? Whether it is systolic or diastolic murmur. The systole means it is started from the first sound to the second sound, while the diastolic murmur starts from the second sound to the third sound. And some secret you can tell about that the diastolic murmur is difficult to be here in the pediatric age group or the undergraduate. So concentrate on the systolic murmur. And what we mean by systolic murmur? That it started from the first sound till the second sound, while it's covered the whole systolic area, while the ejection systolic murmur, it started after the first heart sound and ended before the second heart sound. But the next criteria is the grade. Yani we classify the murmur into grade 1, which is difficult to be listened, while grade 2, which can heard by the stethoscope, and grade 3, it is more obvious, while if it is associated drill, that means it's grade 4, and if it is more obvious with the drill, we can call it grade 5, and the grade 6, that means can be heard without a stethoscope. The quality mean the quality mean whether the soft murmur or harsh murmur. You know that in the small VSD usually the murmur is harsh. The harsher the smaller the VSD, while the large VSD, because less turbulence, it usually soft murmur. The last point to be checked in the auscultation of the murmur is the radiation. That means the murmur can be heard in the same intensity or the same grade to that area. So usually the mitral radiates to the axilla, while the VSD murmur can be heard all over the precordium. The pulmonary usually radiates to the back, while the aortic murmur usually radiates to the neck. So before you get out your stethoscope, you should put a differential diagnosis, because it is usually the next question you ask is what's your differential diagnosis, or what's your diagnosis, or mean what's the underlying pathology that caused that murmur. So before you get out stethoscope, you have the time to think and decide what is the murmur mean, whether it is related to the mitral, tricuspid, congenital heart disease, whether it is stenosis or incompetence.